Hello, colleagues. In this video, we'll walk through a clinical case involving the placement of a bridge on implants and a comparison of different multi-unit abutments. For demonstration purposes, we 3D printed a model to clearly show the bridge installation process step by step. Before beginning, I'll trim the soft tissue on the model to improve visibility and allow for a more detailed demonstration. Here we have an angled multi-unit abutment. It features a tall cone which makes crown seating easier, an obvious advantage. However, it also has some limitations which I'll now show. On this model, we've placed two such abutments. Notice the direction of the cones. One is upright, the other is angled. Ideally, implants should be placed vertically or with minimal deviation, but in reality, they often end up at various angles. When implants are angled, the tilt of an angled multi-unit may create an undercut. I doubt this would ensure passive seating or secure fixation. Now let's compare with PRO multi-unit analogs. These newer multi-units avoid the cone interference issue entirely. They're significantly shorter, eliminating the undercut and allowing the crown to be reliably secured on two multi-units. Implant angulation no longer matters, and crown placement becomes straightforward. This simplifies the entire workflow. Here is the crown we'll be installing. Note the two access holes, one small, one large. Why the difference? A 4mm sleeve allows us to secure the crown with a screw and use a small hole for the screwdriver. This is especially helpful with small components and gives an aesthetically pleasing result. However, in this particular crown, we cannot use two 4mm sleeves because they would collide. So we'll use a 3mm sleeve with a larger hole that allows the screw to exit freely. Its length is too short to embed the screw fully. Before bonding the sleeves, we must ensure the crown seats securely on the multi-units. These teeth are convergent, so if the crown doesn't fit, we need to make slight adjustments to the contact points. Once fit is confirmed, we proceed to bond the sleeves. Multima provides sleeves in multiple heights, making it easy to adapt to clinical needs. To avoid confusion between the 3mm and 4mm sleeves, the 4mm sleeve is marked with a blue tip. Before bonding sleeves to polymer or zirconia, I create small retention grooves with a ball burr. This is necessary because after milling, the surface is smooth, and a micro-textured surface improves adhesive retention. Zirconia sleeves are grooved before sintering. Our digital library defines the screw channel profiles, ensuring there's sufficient material between sleeves to prevent tissue pressure and allow for access from different angles. Now we install the sleeves. We insert the screws, apply an ample amount of composite, and press the sleeve into place. We start with a 3mm sleeve, then install the longer 4mm sleeve. It's easier to hold and work with. It's crucial to insert the sleeves horizontally, especially when the holes are large, to prevent the screw from falling out. We remove excess adhesive and seat the crown. When dealing with converging teeth, the low-profile cones allow for horizontal access, either vestibularly or lingually. We seat the crown, stabilize it, and insert the first screw, starting with the distal one as it offers easier access. Once the first screw is in, the crown won't fall off. Then we place the second screw and cure the adhesive. We remove the screw from the larger hole. Before removing the crown, this is the perfect time to check occlusion. If it's high, we make adjustments. We then unscrew the second screw from the small hole, which remains inside the crown. We remove the crown for final finishing. Now we have a solid fixation. We polish the surface and remove excess adhesive. Note that the adhesive didn't enter the channels as it was displaced outward. We then place the crown for final seating. Here is the finished crown. We've refined the plastic and zirconia edges. We had extra material to work with, which allowed us to create a soft tissue relief zone. We also relieved the intersleeve area to eliminate gingival pressure on both sides. The sleeves are well bonded. If we view it from the side, we can see a slight gap. This isn't critical. In a lab, such a gap wouldn't exist, but then the structure wouldn't have passive fit. We fill the gap with adhesive. The gap is above or at the gingival margin, so even if microbes enter, the implants are protected. Most importantly, the entire structure is passively seated, ensuring long-term durability. The case is complete. The gingiva is properly supported. The same applies to the opposite side. No soft tissue pressure and passive adaptation to the implants. We've met all our clinical objectives and achieved a successful outcome. Thank you for your attention.